That's the whole different ball game. All right.
Yes.
We got people coming in, so I'm busy writing here, and we'll certainly get to you. So let me see, Paul Frida. I'm afraid that I'm writing down in no particular order, so people will have to forgive me for that.
We have a couple people on the phone. Would somebody like to speak up so we can add some names?
Hi, this is Peter Monaco.
Wait a minute. Let me get one at a time.
Okay.
Say again, Peter Monaco?
Peter Monaco, yes.
Okay. Give me a minute to type that in.
Peter, that's the last name of my grandmother's maiden name.
Oh, yes? Okay.
Yeah, are your folks from Italy?
My ancestors are, my grandparents were born in Italy, but I guess I'm second generation.
Yeah, me too. Do you know where?
My grandfather was from Naples, and my grandmother was from Calabria, which is near Sicily.
Yeah. I know where that is.
Monaco. So my grandmother is from the Naples area, a little further south of that. Just a little further south, Salerno.
I had a really good friend, Len. I was at Chase when I trained at Chase, called Margaret Monaco. She was from New Jersey, and she
really that was my mother's name was Margaret.
All right.
Yeah.
She went to work for. She became chief financial officer at the Gap. She went to Columbia.
Oh, really?
Yeah.
Wow, fantastic.
And I've kind of lost track of her, but she was really, she was great. She was really a good person. I'm going back about 40 years. So.
Was it Hoboken, Rick?
I don't think. No, I think she was from somewhere more inland, but I'm not certain. I mean, not that far, but from one of the suburbs. I don't think she was from Hoboken. I kind of feel like Hoboken is like in a city, There just happens to be a river between one part of the city and the other part of the city.
Yeah, it's true.
Okay, I'm sorry, I interrupted Jake. We're trying to figure out who's on the line. So who else called in that would like to identify?
Dennis,
well,
one at a time, please. Okay, Don Price, we got you. You're on video. Somebody on telephone.
Dennis.
Jay Curran.
Jay Curran. Jay, just speak up one more time so we can get what number you're on.
Jay Curran.
Number 1. Jake.
Yep. We apologize, but when we're trying to add names to all we see is caller 1, caller 2, caller 3, so it's kind of hard. But so we apologize for the initial confusion. Somebody else on the telephone.
Dennis Correa.
Dennis, speak up again.
Yeah, I got him.
It's Dennis. Yeah.
Number 5.
He's playing with us again with his double connections.
Okay.
But we're okay with him.
He gets a special dispensation.
He does.
So who else is on the phone?
Jim Harrington, Rick.
Number 3, Jim Harrington.
Oh, wait a minute. Speak up again, Jim.
Jim Harrington.
Oh.
I think he's 6.
Oh, okay. He's 6.
One more time, okay. Jim. I'm sorry.
Jim Harrington.
Oh, you're right. It is 3. Okay.
Okay.
My bad.
Okay. Number 3, Jim Harrington, who I'm going to see next week. I can't wait.
Yeah, thank you, Rick. We're looking forward to it too. Be great.
What's the occasion?
Well, I'm coming to Tucson to go to Canyon Ranch so since Rick's there, we'll have time to meet.
Okay, great.
2 more people online.
Say it again, please.
John Epler.
Number 6, John Appler, number 6. Hi, John Appler. I like the way those gene stocks are going up, man.
Me too. Me too.
And we have one last person on the telephone.
Eric,
Oh, Eric's on the phone. Okay, number 2.
Welcome, Eric. Don Price, what is going on? You're making me dizzy. Stop moving.
Well, you know,
What is going on with your camera there?
it's 6 o'clock here, and I'm getting dinner ready. So I got to set the table.
Yeah.
I got to finish eating up the food. Maybe I should be off the camera. Would that be better? I don't want to make anybody throw up.
As long as you're moving around like that, yeah.
Okay.
Appreciate it.
Okay. I will do that. It's easy to do, and then I'll come back once I'm in one place.
Here's the problem, Don Price. The problem is, when I see you cooking, you make me hungry in the middle of the conference call, and then what am I going to do?
This would be your problem. You got to eat something. That's what I'm doing. Okay. I'm gonna get my. Just gonna figure it out. Here we go. Okay. Goodbye.
Okay, we'll just hear you.
Right.
I actually love watching him cook. Love watching Tom cook. So, but for the sake
All
of
I'm seeing is the ceiling spinning around. I don't see any cooking.
Right. I'm really just dancing, but it sounds good when I say I'm cooking.
Oh dear. Oh, and
I was already hungry. I was hungry for spaghetti when I heard Len talking about being Italian and Sicily and Naples and everything. I said, So now Don's making supper too. I'm getting hungry too.
Okay.
Good
So,
comfort food.
and I see that Professor Bill just joined us. Great.
Yes.
We have a good turnout here.
So, Professor Bill, since I think I've got everybody, and before I just run down the roll call, I just want to welcome Professor Bill in particular as our newest board member. And we're all really thrilled that he accepted the offer, and look forward to working with him for a very long time, Professor.
Hey, that's what I like to hear. Thanks. I'm looking forward to it.
Thank you. Okay, so the only name I sort of recognize is Peter Monaco. Peter, I think you were on this call a long time ago. Is that right?
Yeah, that's a great memory. It's probably been 2 years or so.
Yeah.
Since I was on the call, so I just wanted to give an update. And
okay. We'll consider you to be like a new person since you haven't been on for 2 years. And yeah, I've got you. And the other thing I very sadly see is that you came to us through Jim Cameron.
That is correct. That was the other thing. I got I do get your emails, and thank you for keeping me on the mailing list. And
Right.
I did see that, and I was very sad to hear that about Jim. Nice fella. I used to see him at the US2 meetings in the Morristown Medical Center.
Right.
He was a snowbird. He used to come up, to Jersey in the summertime and spend the winter down in Florida. I don't know where he was in Florida, but he lived near me and in the Hackettstown area of New Jersey. So yeah, I didn't. When I saw that email, I said, "Oh darn, how sad!" I was really saddened to hear that.
He really had a rough time. Now, do you know Jim Harrington, who we were talking to before? Because he's another one who attends that meeting.
I believe, and Jim is on the call.
Yeah, I'm here, and I try to go every night. I'll go tomorrow night. We meet once a month.
I'm going tomorrow night. Yeah,
oh, well,
Jim,
I'll see you then.
Yes,
okay,
absolutely.
Good. Sit at a table. We'll see where we are.
Yeah.
I'll be there.
Okay.
Yeah.
So I'm just going to do a quick roll call, and then Peter will come back to you. So I see
Sure.
Jake, Hannah, Bill Franklin, Len Sierra, David Sibley, Jay Krupman, Paul Frieda. I think that's Brian in Illinois, I'm assuming. Peter Monaco, Shref is back. Welcome back, Shref. John Price, Jay Curran, Jim Harrington, John Appler, Eric Bookbinder, and Professor Bill. Anybody else?
Spokane Gary.
Oh, Spokane Gary. Sorry, Spokane Gary.
Thanks.
Sorry, Gary.
He's my buddy. You don't forget him. He's my buddy. From Inner Conversations.
And and the reason Bill Franklin's asking about Peter's results, and the answer is yes, and I'd be happy to give him. I'm sure Peter would be happy to share it. I doubt Peter's on because I think he's in transit back to Maui right now. He's flying back to Maui tonight. So if we get a moment, I can tell you what Peter found. Otherwise, he'll tell you next week, and I can tell you right now. I mean, the good news is they found some very slight activity in a couple of lymph nodes, and that's probably what is causing the increase. And he was in Marina Del Rey today to meet with his guy at prostate cancer oncologist, and they're trying to decide whether they should radiate or they should not radiate. So that's the bottom line. He's really happy. He was thrilled with his treatment at UCSF. They basically set it all up so it was all done relatively quickly. He had to have a couple of extra tests. The Gallium thing went well, and he met with Peter Carroll, but it all turned out as well as could be expected. I think what he's maybe even thinking is that he might be able to hold off going back to hormone therapy, but he'll update you for sure when he's on next time. So hopefully that's good enough to put everybody's mind at ease. Do
you know if he was able to use that software? The link I gave him last week.
I didn't ask him. I did speak to him later in the week, but I forgot to ask him. I'm sorry.
That's okay. I was just
send him an email and ask him.
Okay. And you said you were going to try it too.
Yeah, I have not retried I have not redone my put my disc in again. So okay, so Peter Monaco. So what I see here is that you had an RP, you had a radical prostatectomy in the beginning of 2015.
Correct.
And I have you as 64, except that might have been 2 years ago.
Yeah, I'm 66 now, and that is correct. I had the surgery in January of 2015, and it was not curative. The pathology was, difficult. It was seminal vesicle and X-caps and all that stuff. My Gleason was 8 when I went in for surgery. Surgical margins were negative. But post-surgery PSA was 1.5, so that's when the fun began. Mm-hmm. It was at that point, I had the surgery at St. Barnabas. That's when I switched to Sloan Kettering in New Jersey. And they immediately suspected that something was going on because of the 1.5. So I went for an MRI, and they detected that the pelvic lymph nodes, a couple of them, had been invaded, slightly enlarged. But this is interesting. That was missed by the CAT scan that I had pre-surgery. Mm-hmm. So I don't know if that would have changed the strategy if that was picked up prior to the surgery. But nonetheless, I went, for radiation at Sloan Kettering, 40 treatments, coupled with hormonal therapy, 2 shots of Lupron, one in May of 2015 and one in August of 2015. And in the middle of that is when I started they put me through the radiation around August of 2015. I'm happy to say that the results been very good. My PSA has been undetectable since then. And, for what it's worth, for those of you who have a similar case, I guess, the radiation can be effective. I don't know how long, I know I'm on who knows what it'll be, in terms of what the future holds. But my latest PSA test was done just last month in mid-February, and it was again, under 0.05. I go to Sloan for all my tests now. And I'm on a 6-month cycle for blood work and annual exam with the oncologist. So right now, life is good, I guess, as good as it's going to get. Just hope it lasts. So that's my update.
Wow, we like that type of update. We love that type of update.
Well, I'm glad. It's the whole thing about the lymph node. It gets pretty dicey. So technically, I'm a stage 4A, I believe. Mm-hmm. So anyone out there who's on the call or who has a similar case, it worked for me. That's all I could say. So hopefully it'll, from what I read, this could go on for a very long time. But on the reverse side, the PSA can start creeping back at any time. So, you just got to live with that. That's the way it goes.
Who's your doc? I have a name here of Karen Borofsky. Is that your quarterback at Memorial?
She was the radiation oncologist,
right.
And it was her call. When I went to see her first, after the post-surgery failure, mm-hmm. And she immediately suspected the lymph nodes. That's what she said. She said, "Look, your surgical margins were negative. They do remove some lymph nodes as part of surgery, and this I don't understand. Those were negative, mm-hmm. But yet the ones outside the prostate were affected, and she suspected that right away, and the MRI confirmed it. And then now I see the medical oncologist at Memorial Sloan Kettering, a doctor named Han Xiao. She's an Asian lady. She's very good, and they work together, Dr. Borofsky and Dr. Xiao, on my case in terms of coordinating.
How do you spell her last name?
I think it's Xiao.
Okay.
It's pronounced Xiao.
Okay.
Xiao. First name Han, Han.
Right. And is this in I forget. Is it out in New Jersey? Is it Monmouth Hills or wherever it is, or is
it's Basking Ridge?
Basking Ridge. So she's
yes.
in Basking. Well, the reason I ask is because we often, not often, but from time to time, we have people that want to go to Basking Ridge, and to date we haven't had a recommendation there for a medical oncologist. So we've told them that they have to go into the city. Is she a specialized genitourinary medical oncologist, or is she general?
I think she is in the whole urinary, renal,
okay.
That type of stuff. She's not general.
Okay, great. Well, that's really good to know, because we have had folks that wanted to go there, and we can definitely refer them to her. That's why we like to hear these good reports. And thank you so much for checking in. Now I have a bigger question, Peter. My notes say you told us you were slightly overweight by about 10 pounds when you called in before. How's your weight doing?
That's the bad part. Life has been good, for one thing. Yeah. But I do believe, I don't know how long that would last. They say the Lupron can make you gain weight. Mm-hmm. but I haven't been working on it. I haven't been working at it. So I'm probably about 20 pounds overweight.
Yep.
So that's another challenge. I'll be retiring soon. I hope to devote more time to fitness. See, I'm still working at this age, which I don't know why I'm doing it. I'm consulting, and I've been, staying in the game, but I'm planning to get out by the end of May, and hopefully I'll take my fitness a little bit more seriously than I do currently.
Well, there's a great fitness class at Memorial Sloan Kettering in the city. If you can take the train in, and Len, you want to talk a little bit about Donna Wilson's class?
Oh, sure. Every Wednesday at 4:30 in the afternoon at the Benheim Integrative Medicine Center in Manhattan, just up the street from the main hospital at Sloan Kettering. Donna Wilson, a former registered nurse and now exercise guru, runs an aerobics class there, and she's just a lot of fun. And it's a relatively small group, but boy, if you have any aches and pains or problems with anything, she's always got the right answer.
That's good to know. And I've been to the Sloan Kettering. That's where I went for my MRI, so I'm familiar with the facility down there. So yeah, I can get into the city. Certainly, when I retire, I can certainly do something like that. Go in. I'd love to do something like that. I belong to a gym out here. I don't go often enough, and they have aerobics camp classes and yoga classes, and I just need to start taking it more seriously. It's hard to do it when you're working. The excuse, too busy to exercise. But again, I'm hoping to change my habits when I have some more time and I can retire. And again, I plan to spend more time.
Okay.
The fitness and other interests.
Well, you can listen to Donna make a presentation on our website.
Okay, great. Yeah.
Keep on Moving, and it's under the exercise tab, and she made that presentation to us online a few months ago, and you might just get a feel for her, but she's really terrific. And
actually, I saw your email with that link to that. I'll take a look at that.
Yeah,
remember that.
Take a good look at it. Okay, so anybody like to chat with Peter before we move on?
Yeah, Tom Van Zandt. One quick comment. I just got back from the oncologist today, and I'm doing pretty well in general. I always complain when I go there about fatigue. And today I got a physician's assistant who seemed to listen a little more closely than the doctor. So she wrote me a prescription for physical therapy.
Oh.
So that surprised me, but it's something that other people might look into.
Well, we'll come back to you because I'd like to expand on that a little bit. And it's something that I've actually heard of recently, and so we'll talk a little more about it. Anyone else want to say anything before we move on to Peter?
Yeah, I wanted to just make sure I heard Peter Monaco correctly. He's a Gleason 8?
I was a Gleason 8, yes. Yeah, yep.
Yeah.
I believe three cores were affected in my prostate when they did the biopsy.
Oh, you got it pretty early then. It's good.
They got it early, but it was aggressive. This is a real sneaky disease, cancer. I don't need to tell anybody on this one. I was very diligent going for annual physicals, and within that 1 year, I went from a PSA of 1.3 and the usual, just a slightly enlarged prostate for a man my age. And then 12 months later, almost to the day, I had a nasty growth going on and a PSA of 5.4, and that's when we caught it. So, what I've come to learn, and I give other people who don't have this dreaded disease, guys who are 50 plus, that I guess you should be seeing a urologist in addition to your general physician and kind of offset those. You should get a PSA at least twice a year. This whole thing about not the value of a PSA. Boy, I wish I had caught mine 6 months earlier. That's all I can say. It would have made a world of difference, I think, for me. So I tell younger people or guys who, guys my age who don't have, prostate cancer, I tell them, well, if you're not going twice a year for PSA, start doing it now because it can catch up to you, really quick. For me, again, it's an aggressive case. It is, and I was lucky that I caught it reasonably early. Not too late, but not early enough.
Yeah, I'm in the same boat that you were, so I endorse exactly what you say.
Yeah, I didn't realize that. I mean, I was going annually to my GP, and he never recommended to me because there was never anything suspicious going on. My PSA was always low; it was in the ones, But I wish he had said, no, you should see a urologist too at your age, and offset it every 6 months from when you see me. I just wish he had made that recommendation.
I hear you.
But it is what it is.
Well, I can hardly fault him for not referring you to a urologist when your PSA was only in the ones. I mean, that's kind of unusual that you went from 1 to 5 in 12 months, and you were already in your 60s, right?
Yeah, that's exactly right. I went November 2013. My PSA was 1.3. Nothing unusual to the touch, other than, hey, it's a little enlarged, like, a man my age would typically be. 12 months later, almost to the day, I think it was 366 days later, I went and had the blood work prior to my annual. And he said, your PSA spiked to 5.4. Let's see what's going on. And he did the digital, and he said, well, go see a urologist right away. And that's when the whole thing started. So the bump was there, and it was craggy to the touch, from what I understand. So that was pretty fast. It was really on the move. And I'm lucky that I caught it when I did catch it.
Yeah.
Okay. Well, we'll move along. I'm going to go down the list and see who would like to have some time to talk today, and then we'll go from there. So, Jake, anything for you?
No, I didn't get my blood test. So they said it was an unsuitable sample, so I have no reports or no results to report.
Well, all right. We'll come back to you because I've never heard that before, and we maybe just unpack that slightly. But just okay. We'll come back to you quickly. Bill Franklin, anything for you? Bill, anything for you?
Oh. Nope. Just called to listen. I had mute on 2 different buttons, so I had to figure out which one was what.
Well, I thought you'd gone off to pack those kids to bed or something, but that's okay.
They need to start doing that by themselves now.
Okay. Len, anything for you?
No, Rick, I'm good.
David Sibley, I know, has something to talk to us about.
I have an update when you get to it.
Right. Jay Kruckman, anything for you?
If there's a minute or two, that's all.
We can find a minute or two for you. Let's see. Paul Frieda, anything for you? Paul?
No, thank you.
No,
I was
okay.
muted. Sorry.
Okay. Brian Heisey, anything for you, sir?
Nothing today, thank you, Rick.
Okay. Shref, any updates or anything you'd like to talk to us about after we spoke last week? Shref? Is he still with us?
Yeah, he's on. He's showing live.
Oh.
Yeah.
All right. Well, he must have stepped away. I'll come back. I'll come back to him. Don Price.
I do not have anything, Rick, but thanks for asking.
Okay. Well, what's for dinner at least? Tell us what's for dinner.
Well, I've got, y'all may want to throw up, but I have some leftover vegan pizza that I made, and then I just made a big pot of vegan chili. And I made some vegan cornbread.
Ooh, we like that.
Okay, well.
I think we've got close to...
Well, not Jake. I think Jake, you lost Jake as soon as you said vegan, right, Jake?
Yeah, you're right.
Probably lost me too, but that's neither here.
Right, Len.
I think we may have around 20 people. Is there enough to share for everybody, Don?
But yeah, I got a lot of chili.
Okay.
Yep, not a problem. Stop by anytime.
Okay, thank you.
You can do a call from here.
Thank you. Jay Curran, anything for you?
Yeah, I got an update and a couple questions.
Okay. Jim Harrington, anything for you, sir?
Rick, I'd like to ask Eric a question.
Okay. John Appler, anything for you today?
Wait a minute, let me unmute him.
Yes, unmute him.
Just really happy to hear the great news about Peter Kafka. He's a great guy and friend of all of us. And also, my test came back okay, so I'm okay. But I'm really curious to hear more about this exercise being prescribed. If there's any implication that may make it, tax deductible, or insurance may help you somehow. I'd like to hear more about that great comment.
Okay. Well. Hopefully, I think we should have time to get to it. I'll try and make sure we do. Do you want to just update us on? Well, I'll come back to you so you can just tell us about these tests that came back. I know they sounded good, but I'll give you just 2 or 3 minutes if you're still with us. So you can just tell us about that.
I can give you 10 seconds, Rick. It was a standard blood test. TSA was below 0.1. My surgeon called it undetectable, but it was the low sensitivity test.
Right.
And all my other blood tests were great, so I feel pretty lucky.
Good. Okay. Great. I just want to put that into. I just want to put it into my notes here. Eric, would you like to? Well, Jim's got a question for you, and do you have a question for yourself?
Yeah, I have an update.
Okay. Professor Bill, I know you have an update, so I'm marking you in.
Okay.
And Gary, anything for you?
The matter?
No, I'm good. Thanks.
Okay. Tom Van Zant, we'll come back to you on the exercise question if we've got the time. I think we will. And somebody just joined us. Who just joined us?
It's Peter from the airport.
Oh, Peter! Everybody's
I might only have half an hour or so.
Okay, well then we'll put you in first because I gave a quick update on your behalf. I thought you wouldn't mind because we had people asking about you. John Appler, Bill Franklin, and everyone else. So go on. I'll let you go first in case you have to leave.
You ready?
We're ready.
Okay. I'm down at LAX. It's been a whirlwind afternoon. I've been to three doctors and still got to the airport on time through traffic. Anyway, my scan showed a couple of lymph nodes on the pelvis, apparently above where they had radiated 2 years ago. And anyway, so I met with Dr. Carroll, and he suggested SBRT up there, and I met with a young radiation oncologist, kind of looking at possibilities there. Then I came down to meet with Dr. Turner today, Monday. Although Dr. Turner was sick today, so I met with Mark Schultz. And we talked a little bit. He was pretty rushed. He was covering for 3 guys. Dr. Turner and I guess Lamb is on vacation now too, so he was racing around the office. But we had a good short talk, and I put it on speakerphone so my girlfriend could hear. His his thought was he was skeptical about SBRT. He thought maybe more IMRT up above to catch other lymph nodes and stuff was appropriate. Anyway, but he got me in with an appointment this afternoon with Dr. Yampolsky, who used to work with Dr. Rose at the whatever the radiology center is. And I just had a nice talk with him. I gave him the copy of the scans, and he pulled them up and kind of looked at them and scratched his head. He's going to do some research. He's going to have to call the radiology people in San Francisco and see if we can get more information from them, because it was hard for him to see anything. He thought maybe I could get away with SBRT. He wasn't sure. He needs to get a clearer picture, because it wasn't real clear on the scan of what was going on. And Schultz suggested going back on Lupron and Zytiga, and maybe even doing chemo. And so then I get to the airport and I check my messages just before I call you. And lo and behold, my PSA, which I just did it with Schultz this afternoon, has gone down a little bit. Not much, but a hair but that might be just because it's a different place, because I've been getting it on Maui, and then I did it in his office. So it really hasn't changed this time, even though the progression's been doubling every 2 months for the last 4 months. This time it kind of stayed the same.
What was the number? What was your number?
0.73 today, and it was 0.77 beginning of February 8th and February 9th, about a month ago. Anyway, so I've got some research to do. I think I'm going to do a phone consultation with Dr. Turner next week when he gets back from being sick. And kind of spend some time going over things, because I can talk to him at more leisure than I can with Schultz, and kind of get a feel for what's actually going on. So that's where I am. So far it has been designated as metastatic, but it's just small kind in the lymph nodes, and 2 lymph nodes. So it's oligo metastatic.
Right.
And so I've got some, I got some research to do and some things to figure out. I bought a couple of copies of Schultz's new book, which looks pretty good. I bought one for you, Rick. I'll send it off to you once I get. You can email me your mailing address.
Yeah, well.
So Peter. So that's where I am.
Couple of questions I have for you. I think we're all interested to know 2 things. One, why Schultz thought that SBRT would not be sufficient, would not be the right type of radiation, given that there's just these 2 spots that we're seeing. And the second thing is why he's suggesting going in full bore with Lupron and some combination and sequence or otherwise of Zytiga and chemotherapy. Did you have a chance to unpack that with him?
Not a lot, but the way I took it was his comments were that he feels I've got systemic disease, and it's just a matter of time before it starts popping up someplace else. And he felt that just hitting two lighted up lymph nodes was not enough. That it was going to in no time it was going to start showing up other places. Mm-hmm. So he felt more aggressive treatment was necessary, and that's why he suggested the hormonal stuff as well as possibly chemo. He wasn't pushing for it, but he was leaning toward more aggressive treatment because he felt that if you just hit things that are showing, that you'll be back in no time for further treatment.
The old whack-a-mole. The old whack-a-mole.
Whack-a-mole, right?
Yeah.
Right.
How do you feel about all of this?
As I said, I think I want to talk to Jeffrey Turner. I think he's a little more level-headed, and I can actually, go back and forth and carry a conversation with him. And and really look at different things. The radiation place I went to in Beverly Hills, I've met with him, Dr. Rose. He's retired, but I heard Yompolsky speak a couple of years ago at PCRI. He's an impressive guy. He's a young Russian guy from LA. But I'm not sure about the equipment there. They don't have the latest and greatest. And I'm not sure in this kind of stuff to do stereotactic radiation, whether to use old machinery is appropriate. So I'm a little skeptical of that. So I want to investigate this a little more. I'm more inclined to go up to UCSF if I'm going to do SBRT and do something up there. I asked Schultz what he thought about proton with Dr. Rossi down in San Diego, and he wasn't too impressed. He said a number of their patients who've done proton ended up with reoccurrences and problems, and it wasn't all that good. I've got a friend from Maui down there now doing IMRT, and he's having urinary problems already, and he's halfway through. So he's doing self-catheterization. So anyway, I just want to check out possibilities, and we got a lot to mull over, and I'll start doing a lot of research and talking to you guys too.
Well, I think you would know what my feeling would be, and I'll throw it open to the guys in a second. But if you do decide that you're going to get more radiation and you're going to come over to the mainland for it, I don't see why if it were me, I wouldn't go back to UCSF who did my radiation in the first place. But
I'm inclined to think that way.
Guys, let me throw it open so you can ask Peter questions.
Peter, have you had, you must have told me this at some point, but I forgot. Have you ever had genetic testing? Anything actionable?
Yes. Nothing actionable, but I've got a germline thing. I haven't done somatic testing. I've not done the somatic test yet. I've just done germline testing. So
maybe they can.
That's something I can talk to Dr. Turner about.
Yeah, they can do a biopsy of one of those lymph nodes.
They could. I think they're 1 centimeter, or one of them is 1 centimeter. It's pretty small stuff. I mean, it was picked up by the sensitive scan, but I was looking at the scan pictures on Polsky's computer, and it's pretty hard. He was having a hard time seeing anything. I'm not sure what we're looking at.
Jim Harrington, how big was the lymph node that they biopsied for you last week?
They said that they did a couple of lymph nodes. They seemed to have a very easy time accessing it when I was lying on my stomach, and they put me in the CAT scan and came back out, and all of a sudden, poof. I don't know how big they were, but it sure didn't take them very long to do it, and it really didn't hurt very much. They used a lot of lidocaine. And then these samples will be sent to the pathologist to make sure that there is tumor.
Right.
And if there is, sent to Foundation 1. But I don't know how big it was. I think he said he's going to do 3. But, they snap, 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 and poof, it's over.
Right.
And they picked it up on a regular CT scan?
Yeah, I guess so. He guided it. You see, he's going through your back, and in my case, the lower left side, and you're on your stomach, and he puts you in the CT scanner, and they bring you back out. Then he pokes the thing in, puts you back in the scanner, pushes a little further. But he did it pretty damn fast. He said it would take an hour. It took 10 minutes. I think what I got from the interventional radiologist was that it was fairly easy to access these lymph nodes, or lymph nodes, I guess. I don't have too many lymph nodes that are involved. I got bone mets. Anyway, seemed like it was pretty easy to do. There's a little bit of pain, and once the probe comes back out and he's finished, he puts a bandage on it. It was a little bit sore that night on the outside. Not where he actually biopsied. So I guess he seemed happy. Sure did it pretty quickly. I think the key is that when they stick a probe in you, that they don't hit something that they don't want to hit.
Yeah.
And he seemed to, I think just 1 or 2 CAT scans is all he needed to be sure that the probe would strike, and that's what happened. So it's over now.
And if you've already got bone mets, what's the purpose of
well, he's I was told that biopsying the bone mets gets very little sample. But when I have it in the lymph nodes, so yeah, I know. I thought the same thing. Believe me, I just wanted to just go in the bone. It didn't sound very good, but since it was in a lymph node that was on the left side, and they could see it in the CAT scan. He also had a radiologist report from our local radiologist here, so he had something to go on. But they do it themselves. This was done at Robert Wood Johnson Hospital in New Brunswick, and he just seemed to know what he was doing and went pretty fast. But they knew that there was a lymph node or two in this area that had tumor. Well, at least I hope so.
Okay, great.
Yeah, and I think the other.
So I mean, it wasn't bad.
The other thing for Jim was that I think that some of his tumors are in a sensitive place, so they may not be that easy to biopsy.
Yeah, they could have been Rick. It turned out not to be so hard. I thought they were going to have to, kind of gingerly go at this thing and take a long time in and out of the CAT scan, but it didn't seem to be the case. So.
Yeah.
Great.
Anybody else would like to talk to Peter?
I would like to ask Peter a question. Peter's Jay Kruckman, and you and Rick have suggested this Gallium-68 scan as well. And come to find out, I'm getting pretty claustrophobic on some of these things. Can you enlighten me in regards to what that scan entailed? Is it a CT scan or an MRI machine?
It can be either way. It's a PET CT or a PET MRI, depending on which way the doctor wants to go, depending on your situation. And it's a combination. It's all one machine. The front end is usually the PET, then the back end is the MRI or CT, and it automatically puts them together, the image together. I didn't feel too claustrophobic. Mine was pretty big too, but it wasn't. There was plenty of room. I mean, there was probably a good 2 feet above my head to the top of this thing, so I didn't feel claustrophobic. You have to lie still. I had to lie still for 35 minutes, and they empty your bladder. They give you a Lysic or something to to make sure your bladder's empty so that you don't have to urinate. And I made it just to the end. Then I had to get up and urinate. They said if I really had an emergency, they would have stopped it with no problem and let me get up and get back in. But I made it for the 35 minutes. I didn't feel closed in at all.
Okay, that was at UCSF, right?
Yes, it was.
Okay, they told me it'd be about an hour, and that's why I was kind of questioning that. That's a long time for me. But.
An hour in the machine?
Yes.
It's an hour. It's an hour to get for the gallium to course through your body, and then they put you in the machine.
Okay.
For me, it was only about 35. I think they use an hour. By the time they set you up and everything, it's probably an hour.
Okay.
But you're not really in it for an hour. At least that's what I wasn't anyway. Maybe the MRI is a little bit longer.
Did you have to leave your hands above your head the whole time, Peter?
Yes, and that was a pain in the butt or a pain in the arm. It was it was uncomfortable, locking your hands and
That's what I found too. I found that this is Jake. I found that PET when I had it was easier to tolerate than the MRI. I'm claustrophobic, but the PET is tolerable because it is, like you said, a little bit bigger. But the big trade-off is you have to sit there or lay there for so long with your arms above your head.
Yeah, and it's stretched out above your head. It's not like arms behind your head. It's they're way up and locked up above your head.
Yep.
Peter, can they do? You said it's the choice of the doc. So can they manage with just one or the other, or do they have to do both?
Just one or the other. I did the PET CT. I think the MRI is more. What was it? If you haven't had a prostatectomy, I think they usually use the MRI. But if you have had a prostatectomy, I think they usually go for the CT because they get more reading on bones and so forth with the CT.
But either way, they're using the tube, they're not using the donut.
Right. Yeah. You're in a tube.
Okay.
But it is a bigger tube.
But
it is a bigger tube, Rick.
I see. Okay.
Yeah, and it's bigger and it's open on both ends.
Right.
Yeah, you can look. You can actually look out and see like pictures on the wall or whatever with this PET, which you cannot do with the MRI.
Okay. Okay. But do they need? They don't need to do both, Peter. Is that right? They can.
No, they didn't. No, just one or the other.
I see. Okay. Okay. Thanks for that clarification. That's really helpful, I think, to a lot of guys. And that was a great question, Jay.
And they give you the results right away. I picked up the scan as I was leaving the disc, and then 2 days later I had the printout of it. Yeah, so of the report.
Mm-hmm.
So they're pretty fast. They're giving you.
Were you able to use that software? I put the link on for you.
I didn't try it. I didn't try it yet. I thought about it, but I didn't try it. So the first time I looked at it was the scan was today at this Yampolsky's office.
Right.
He loaded it. It's pretty complex. I think if I looked at it, I don't know what the hell I'd be looking at. I mean,
well,
they tell you what pictures to look at, where the stuff is, but it would be I couldn't see anything popping out for me.
I think you're right. I couldn't see anything either, but you said you wanted to try looking at it last time, so I figured, well, try this software.
Right. Yeah, they don't pay me enough for that.
Right.
Any other questions for Peter before we move on?
Jay Curran.
Peter, go ahead, Jay.
What was your nadir on your PSA, and for how long before it started up?
I was undetectable at 0.08 until September of last year. And then October it jumped up to 0.17 or 15, and then November 0.23. And then it went up to 3.4, then it went to 5.1, and then in February it was 0.77. So it was doubling every 7 weeks.
Okay.
Thank
you.
But
it was low. It was under 1. It was under 1.
But Jay, you also should be aware that Peter's not castrate resistant. He was on a Lupron holiday, so he came off of ADT.
Okay.
I'd been off for 14 months.
He's been off for 14 months. And how long did you stay? How long did you stay undetectable after you came off, Peter?
I made it for 14 months.
Right, but how many months was it before, from the time you stopped?
Oh wait, no. Yeah, okay. It was from this. I think it was. Let me think. No, 18 months from when I finished radiation until I was detectable.
Okay.
But I was on ADT for 6 of those months. So from the time I finished ADT until I came here, it was 14 months.
And how many how many of those months did you stay undetectable before your PSA started to become detectable?
Let's see.
Roughly.
Well, let's see. I finished radiation in March of 2016, and I made it until September, October of 2017. So about 18 months.
Right, but I'm trying to figure out from the time you stopped your ADT and
that was December of 16 until December of 16. I stopped ADT, and then October of 17 I started showing up again.
So you got like 9 months when you weren't on ADT and you were still undetectable.
Right.
Right. That's my question. Okay. Anyone else? Any other questions? Otherwise, we'll move along.
Okay, thanks, guys. I'll keep you updated.
Peter,
Let you know. Hey, Peter.
Home.
Yeah.
Have a safe trip home.
Oh,
I'll talk to you tomorrow or Wednesday morning.
Great.
Okay.
Hey, Peter.
So long, Peter. Safe travels.
Before you go on, Rick, excuse me.
Sorry, what did you say, Jake?
I was going to ask John. I was going to ask John Appler to mute himself until he wants to talk, because we're getting a lot of feedback. I keep muting you, but then we won't know if you're trying to say something. If you can mute yourself on your phone, then we'll be much appreciative.
Got it. Sorry, Jake. I will do.
Thanks.
Okay, thanks.
Thank you, John, and thanks, Jake, for being the policeman.
That's okay. That's why you pay me all that money.
That's it. Damn right. Damn right. I'm giving you half of what I'm getting.
Okay.
Okay. So, David Sibley, why don't you give us an update on your situation, what you found out today, and your decisions for moving forward with your treatment?
Yeah, I'm doing preparatory work to go into a clinical trials. And part of that involved a PET scan, a CT scan, and during that process where the lymph system is more involved than it had been in the past. And so I'm still going to go to UCSF for the clinical trials, which is going to start in about 3 weeks. I still have to do a EKG and blood work prior to this clinical trials, and at any time, if I could be disqualified during these preliminary tests. So I don't know what to expect. Last time I visited with my doctor, Freelander, we talked about the options of doing nothing, and that option, he said, well, if you choose that option, he said, I will recommend hospice for you. So I said, well, then we might as well try the trials. So I'm kind of in that spot. The cancer seems to be spreading, moving around. It is in the bones. It is in the lymph nodes now. It's not in the organs. So I'm just in that process of prepping for this clinical trials.
And the scan that you got back today showed greater lymph node involvement. Is that what you're saying?
Yes.
How about your bone mets?
Bone mets are fairly well. You know, they we talked mainly about the lymph nodes, which is in the abdomen, chest, and then there's one under the arm. He talked about, now this is my general oncologist today, talked about maybe doing a biopsy on that particular lymph node that showed showed up on the PET scan.
So this is your local guy again, right?
Right. Yeah. I had the PET scan done locally, the CT scan locally, which were both done at the same time. But I will have to go to San Francisco for the EKG and the blood work.
Now, what is the test? What is the trial? Is this for the ES414?
Yes, and what I did learn something about that. The original drug manufacturer, there was something about they sold the medication to another pharmaceutical? I'm not sure about that, but that's just some talk I heard when I was at the doctor's office. And originally, when they tried this medication, they tried it as a weekly infusion similar to chemo. And they weren't happy with that because the body was building antibodies against this medication.
Right.
So now this study that I'm going to be involved in is be a continuous drip through a port.
Right.
I'll have a pump, I'll have medication, and I'll have a port.
Right.
I'll go to San Francisco twice a week to refill the medication.
Right.
And do testing.
Right. So a couple of things that I sort of understand, and I may have said this before, so forgive me if you've all heard it, and this is really layman, but my understanding of this ES414 is that the drug is infused and it goes to two places. One place is to the T cells, and the other place is to the tumor because it's attracted to PSMA, prostate-specific membrane antigen. So any place where there is prostate-specific membrane antigen, this ES414 will inoculate, if you like. And then there's like a magnetic effect where the T cells are attracted to the other place where this ES414 is. So it kind of pulls the T cells in to the tumor. Now, this trial is an old trial. It's about 3 years old, but I believe what happened was, as David correctly explained, they were administering it in a different fashion and it wasn't effective. And so they made a decision to try it as a continuous administration where you have to wear a belt and so it's infusing all the time. David, how long does the trial last, and how long do you wear the belt for? How many infusions are there?
Well, it depends on how well you react to the treatment. See, week 1, they'll give me a dose and I spend 2 nights in the hospital. If everything goes well, they send me home. And on week 2, they're going to escalate the dose and I'll spend 2 more nights in the hospital. And I would think each week as I go back, they will do testing. And I would just think that if there's a point where we're not showing any improvement, that they might boot me out of the trials.
Mm-hmm. But you don't know what I guess this sounds like a phase 2 trial where they're trying to establish dose. So
right, this is dosing, right.
Right. So do we know what they think a normal dose might be, and if it were approved, how many infusions you would get of this ES414?
Well, they actually said it could go 6 months.
Okay.
And if we show improvement, then they can continue it at their discretion.
Okay. Okay. And what about wearing this belt? I mean, can you shower? Can you? What are the impositions on the quality of life when you wear this belt?
Well, that's a big question. From what I'm gathering, no showers. So of course I'm worried about the sleep part of it.
Yeah.
Because I am somewhat of a restless sleeper. So I'm just figuring out that I'll have to build myself a lounge chair that once I get in, I can't move around. So. But I haven't seen the apparatus, so I don't know what I'm dealing with there.
Right. Now, you met with Terry Friedlander, who is your resident doc, your quarterback at UCSF. Are you going to have to meet with Larry Fong again or not? Or
actually, Freelander was the lead in the beginning. Once I switched to the trials, it'll be Dr. Fong. They did mention a Dr. O.
Yeah.
Does that name sound familiar?
The only Dr. O I know is Len Sierra's Dr. O in New York.
Oh, well, probably not the same one.
Okay.
You know his first name?
No, I do not. I haven't met with him. I have met with Dr. Fong. So, I'm just leading up to this point where we're going to get involved, and I'll know who is the lead in my case.
Right.
Now, Freelander will remain on the team, but he won't be the lead anymore.
Okay. Okay. Well, Fong and Friedlander are two of the best. Not just in terms of their medical ability, but in terms of how compassionate they are and how well they relate to the patient. That's my personal opinion. I know them both. So for me, you couldn't go wrong with either of those two.
Yeah, I didn't spend much time with Dr. Fong, but I did meet with some of his team.
Okay.
And I would suspect next week I will be getting appointments for the EKG and the blood work.
Okay, well, we'll keep
that'll be up there.
Fingers crossed for you.
I still have a bone scan to do later this week, and that's part of the preliminary work for this trial.
Well, if you happen to see Larry, just tell him we said hi, and he's on our advisory board. He's one of my favorites. He's fantastic. But one of the big problems right now with Larry is that he's so busy, so he's not a great person in terms of taking new patients and what have you, as you rightly point out, but he is very special. Who would like to, there's probably a bunch of questions you want to ask David or others. Who would like to speak up?
This is Bill Burhans. Let me just say that your description, Rick, of how this works was pretty much on the mark. It basically, it's a monoclonal antibody that binds both to the PSMA on the surface of tumor cells, and it also binds to T cells. So it sort of acts as a bridge that that localizes the T cells to the cytotoxic T cells to the tumor cells and kills them. As far as the drug is as far as the fanny pack is concerned, I had a fanny pack for about 3 weeks back a couple of years ago for a trial of the intrathecal pain pump that I now have installed inside me, and they wanted to make sure that everything would work from an external pump before they implanted the internal one. And so it's, I think having that pack will be similar. It wasn't much of a problem. It didn't, I don't recall that it became a problem when I was sleeping, for example.
You had a port installed?
Yes, that's right.
Okay.
So, so that's just, I'm throwing that out there.
Yes, I appreciate it.
Digest, yeah. As far as the effectiveness is concerned, I think it's a phase 1 clinical trial. Is that correct?
I think it's phase 2 now. I don't know how they determine that, but we're going from a weekly infusion to a continual infusion. That sound like it might be a phase 2?
Well, that's not really the determining factor, but you don't know. If they're trying to determine the dose, then that's probably phase 1.
Okay.
If they're trying to determine how effective it is, then that would make it a phase 2.
Okay.
But it sounds suspiciously like a trial that was offered to me by my oncologist recently. And I decided against it mostly because it would be it would involve returning to the clinic so frequently that it would make it difficult for me to travel.
That was a drawback for me, is going to San Francisco twice a week, and of course then that always includes a family member or two for transportation.
Right.
So so it can get quite complicated.
Yeah. I mean, I would have been able to do it right here where I'm being treated, but the need to return 2 times a week would have put a big, I'm still traveling quite a bit, and it would have made it impossible to do that over the.
And yes, you're right there. That means traveling is out. So.
Yeah. But in any case, the fanny pack, may not be much of a problem.
Oh, good. Thank you for that.
Thanks, Bill. That's great. Yeah, I forgot that you had discussed the ZS414 with Dr. Chatter.
Right.
There are 4 centers doing this, and Dr. Chatter, who is Bill's oncologist at Roswell Park, is one of the centers. So it's almost certainly the same trial.
Yeah.
And Bill, I am confused. I thought phase 1 was for safety and phase 2 was for dosage.
Yeah, I believe that's true, Bill.
I may be, I may be getting confused. I'm quite tired.
Okay.
Yeah, phase 1 is safety. They're looking for the maximum tolerated dose, and then phase 2, they're dose ranging for the most effective dose before they go into phase 3.
Yeah. Okay. That's what I did mean to say that. I didn't express it very well, but that now that you've jogged my memory, that's correct.
Right. So it sounds like it is a phase 2, David. Anyway, look, we need to move along here. I'm going to the rest of you forgive me. I'm going to promote Professor Bill because he has the floor and he sounds pretty tired there. So, and I know there's a bunch going on. So, Bill, why don't you just update everybody on your own situation, and we'll discuss. We'll open it up and see what comes out of today's group.
Okay, so the news from me is that my PSA is beginning to climb rapidly, and I went early last week, I went to Dana-Farber in Boston for a consult with a fellow named Atis Chadawi, who is a DNA repair scientist in addition to a clinician. So he speaks my language and is familiar with BRCA positive disease more so than many other oncologists. And he suggested that I go on Xofigo or radium-223, which is, I guess, surprising. It's not usually used at the stage where I'm at. But he felt that that there might be a unique window where it might do quite a bit of good, combined with my BRCA2 mutation. And that's based on a couple of case reports which showed that other patients with a pathogenic mutation in BRCA2 responded extremely well to Xofigo. And that makes sense because it's the mutation causes double-strand breaks in DNA, and as does radium-223, and so the combination is synergistic in tumor cells. So he that was his recommendation, and he told me that he would be willing to follow me if I could receive this treatment at Roswell Park. And we made plans to come back in 6 months to see how well it worked and then assess things beyond that point. We also talked about some other possibilities that included a couple of clinical trials that combined, in one case, an inhibitor of a protein called ATR, which is also involved in DNA damage responses, similar to BRCA2, with Xofigo 223, but his current concern was that that combination will be so toxic that it would wipe out my red blood cells to the point where they would never recover. So, that's certainly a scary outcome, and I am not willing to take that risk. And he also agreed that the treatment that was recommended before that by my oncologist at Roswell, which was to add Keytruda to the olaparib that I've been taking, which is no longer working terribly effectively, obviously, since my PSA is shooting up, would also be another reasonable option, although he seemed to think that Xofigo would work better. And then he also, said that I should consider cytotoxic chemotherapy in the form of something like cisplatin, which for a BRCA positive patient can, work more effectively than it can for other patients. So I went back to Roswell as soon as I got back I went to Boston from Vermont, and I returned to Buffalo from Vermont last week and met with my oncologist there on Thursday, and found that my PSA is continuing to rocket up. It went from about 4.69 before I left for Vermont at the beginning of February to 11.7, something like that. That's reasonably close, somewhere 11 something. So that's pretty fast, and it seems to be accelerating. So my oncologist at Roswell was dead set against Xofigo. He said he wouldn't sign off on it. And he thought that the nuclear medicine guys would not sign off on it either. So that means that I would, if I decide to go that route, I'll have to go back to Boston every 4 weeks for the injections. He still thinks that the Keytruda is the, probably the best route to go. I'm skeptical because, anti-PD-1 immunotherapies in general don't work very well for prostate cancer patients. And they do work better for patients that have DNA repair defects, but not the kind that I have, which is, it's not, there are other types of DNA repair defects other than the one caused by the BRCA2 mutation that would be more, appropriate. So So he's scrambling to get that going as fast as he can. And in the meantime, we talked about, I had had a bone scan right before I left for Vermont at the beginning of February. And curiously, the bone scan really isn't showing much still. It hasn't shown much for, since before I went on olaparib. There are clearly some lesions there, but they're not very big at all. And, some of them are getting smaller in size and some of them are getting larger, but they're still all very small. And I also had a CT scan that detected some potential disease in lymph nodes, but they're still sub-centimeter. So, they're also small too. But just since I saw him, I'm realizing that I'm beginning to feel some of these metastatic lesions. They're very definitely, they're in my ribs. So that's lending a certain amount of urgency to the situation too. So the way we left it was that I'm going to try to get, I'm going to try to have tumor DNA sequenced to determine whether I have a microsatellite instability caused by a defect in mismatch repair, which is a different type of defect. And it's the type that would be suitable for treating someone with Keytruda. And my urologist has offered to go back in and get some primary tumor to test for that. And so I may take her up on that offer, but the problem there is that the looking for actionable mutations will be worthless, because that the primary tumor evolves very differently than metastatic lesions. But it would tell me whether or not I have mismatch repair defect and microsatellite instability. But the guy in Boston also steered me towards a company called PGD, which has a liquid biopsy that it's the only company that will that's capable of detecting microsatellite instability in a liquid biopsy. And so I'm going to try to, before I have my urologist go back in again, I'm going to see if I can get that test. The advantage would be that they would also look for mutations in a fairly large panel of genes, so that I might get some information about what's actionable and what's not. So that's pretty much where I'm at.
So let me just ask you a couple of things, Bill. That's a lot to take in. No wonder you're tired. Yeah. So first of all, just a clarification. You mentioned that they were suggesting a drug that could be used with the olaparib, but the combination would be too hard on you. What was that drug?
I don't know the name of the drug, but it's an inhibitor of a protein called ATR, or ataxia-telangiectasia related. You don't need to know that stuff, but it's a protein involved in DNA damage responses. Right.
Okay.
So similar to BRCA2.
Okay. Secondly, I mean, what's all your feeling about this? I mean, it looks like you're being put in a position where, well, let me step back one. Who is it at Roswell Park that's so opposed to the Xofigo? Is it Chada, or is it this I don't know the lady's name, the lady that you see?
No, it's Chada.
It's Chada.
Yeah, the woman is my urologist, and
okay.
She deals with all the the secondary effects of treatment, and not directly with cancer.
Okay. So what's your feeling about being placed in a situation where either it's chatter or it's Dana-Farber? I mean, it sounds to me like Cheddar's nose is bent out of shape that you went to Dana-Farber. You know, they could have recommended that you take large doses of honey to cure your disease, and he would have been opposed to that.
Yeah, I'm not happy about it, actually. I want to talk to I need to talk to the head of nuclear medicine, who's a friend of mine,
Okay.
to see what he thinks about Xofigo, and he could actually order it, and so I wouldn't have to go to Boston. But yeah, I'm not, to tell you the truth. I mean, Chowda is I like him in many ways, but for many reasons, but I'm not happy in other respects, and particularly because he's not terribly responsive.
And what about? I mean, what's your own gut feeling here? What do you think will work best?
I think probably that the Xofigo will, but it would be a very unusual strategy for Xofigo is usually used, I think, much at a later stage.
Yeah.
I mean, but I do have this mutation, and so I can't. It's difficult to comparing me to other patients is comparing apples to oranges.
So
and I think that the logic of his reasoning is sound, that I might respond much better.
Right, because of this double action, because of this synergistic action on the double strand. But here's my concern, and not really a concern, but it's something that I think would be worth discussing with Chowdhury. The Xofigo is attracted to calcium.
Right.
What if you were to use a different radionuclide that was attracted to PSMA? Would that still have the same synergistic effect?
Yeah, anything that localizes the radioactivity to tumor cells will potentially kill them effectively. I mean, that's the whole idea. In the case of radium-223, it's just it localizes there because of because of the turnover of bone, because of bone metabolism, rather than because it binds to the surface of tumor cells. But anything that actually bound to the surface of tumor cells, as would be the case for PSMA, should theoretically have a similar effect.
So I want to suggest something to you to look into. I think we've talked about it before. And I think I have Len to thank for this, or Rob, I can't remember, but there's a trial going on with a radionuclide PSMA agent at Memorial Sloan Kettering called iodine 1331. I'm going to put the trial in the chat window for you right now. And
okay.
The thing is that, as you know, lutetium's available, but it's very expensive. Dr. Steve is doing it. And I don't think that there are any lutetium trials that are available. But this iodine 131 trial, I just posted it. I believe is a PSMA sensitized agent, and I don't know if you would be eligible for it or not, but even if you weren't, you could call them up and talk to them, because your special case with the BRCA might make them say, yeah, we'd like to see what the impact might be with it.
Yeah.
Now, I forget who the PI is on this. I think it's Michael Morris, who we kind of know because he was Dom, God rest his soul's doc. But
yeah, it is. I'm looking at it. It is Michael Morris.
Right. And we probably, we could probably get to them, get to someone if you can't get, or if you can. But I think it might be worth just looking into that, because an agent that is PSMA attracted would have a lot less side effects for you than one that's calcium attracted. And you wouldn't run the risk of the bone marrow issues.
Right.
The myelosuppression.
Right. Okay. Yeah. No, that sounds good. I'm going to look into it for sure.
And tell us what you find out with this PGV as well, because that's very interesting. I mean, I do know that you have to have a high microsatellite instability for the pembrolizumab, the Keytruda, to be effective. Let me throw it open to other folks here. Who else would like to ask Bill any questions about his own diagnosis? I'm sure Len would. Go on, Len. You're up first.
Sorry, I had to unmute. Yeah, Bill, for Keytruda, usually they like to screen you for PD-L1. Is that a possibility?
You mean, what do you mean screen for PD-L1?
PD-L1 expression, programmable death ligand 1.
Yeah, no, I know what it is, but I didn't realize there was a screen for it.
Oh, yeah, there is a test. I think it might be just a blood test.
Okay.
And my understanding is that if you're not expressing PD-L1, that they would not give you Keytruda.
Yeah. Okay. This is the first I'm hearing about it, Len, to tell you the truth. And
Okay.
I mean, I knew that it works by that mechanism that involves PD-L1, but I didn't realize that some people don't express it. And Chada has not said anything about undergoing that test, which is strange because he is taking the time to get approval for it. And it seems like it's a waste of time if it turns out that I'm not expressing it.
Yeah, I would think so.
Yeah.
And
all right.
the other question was,
that's very helpful. Thanks.
Sure. Do you know what your platelet count is?
They've generally been lower than normal, but not by much. And that's presumably due to the olaparib. My blood counts across the board are generally run low.
Right, because I know Dom's biggest problem after Xofigo was very low, dangerously low platelet counts.
Yeah.
Yeah.
Yeah, he was down to the 50 or 40. I think, as a matter of fact, he was getting transfusions, platelet transfusions or blood transfusions.
Yeah. Jerry, same thing with Jerry.
Yeah.
Yeah. Well, this is a big concern
right.
for me, which I discussed with Chowdhury in Boston.
Right.
But he seemed to think that it was worth a shot. I mean, he said that it would be just not. I'm sorry, I'm not being very articulate. Combining it with olaparib, I'd have to stop taking olaparib because of the potential toxicity of the two together.
Mm-hmm.
Right.
But But, and he said that this was a potential problem, but he thought that it was worth taking the risk.
Right. And was there any discussion as to whether it would make any sense to just escalate to one of the more potent PARP inhibitors?
Yes, there was. I forgot to say that. So I think I've told you guys in the past that Johann de Bono, who's the guy who developed olaparib in England, suggested to me back a couple months ago that I try to get access to a next generation PARP inhibitor, but only if I had evidence that the mutation in my tumor DNA, the BRCA mutation, had not reverted. And he published a study recently that showed that that can happen pretty frequently in prostate cancer patients. So, so that's another reason why I'm trying to get my tumor cell DNA sequenced. Sorry, I lost my train of thought.
You're there.
Oh yeah. So Chowdhury, when I related this to Chowdhury, he was dismissive. He said, "I don't know of any next generation PARP inhibitors that work better than olaparib." So I don't, I'm going to have to do some research. And I'm going to contact Johann again to see exactly what he had in mind. I do know that the next generation inhibitors in preclinical studies show orders of magnitude greater cytotoxicity. But of course, that doesn't necessarily translate into more effectiveness in the clinic.
Right.
Okay. Anyone else? Otherwise, we'll move along. Bill, keep us posted.
All right. Well, thank you guys. This was really helpful.
Right. Follow through on those leads, and I think at least we've come up with a couple of interesting things for you to follow through with. See
absolutely.
Takes you. We had another caller. I don't know if that. Yes, somebody else called in. Who might that be? And I'm sorry it took us so long to welcome you.
This is Sebastian. I apologize to everybody. I ran late today.
That's okay. We'll put you in, Sylvester. And I think we had somebody else on there who came and went in between, and I feel badly about that. I'm sorry.
I do too. I'm sorry that I took so much time.
No, it wasn't you. It was before you. It had nothing to do with you, Professor.
Joe Gallo, he was on and then he disappeared. So
yeah. So it doesn't matter. He'll come back. It was a name I hadn't seen before, Joe Gallo. Oh, maybe I have. I think he was on a long time ago too. I have to check it out. And I also want to welcome Shref. We spoke to you before, but you were gone. I don't know if you're back with us. Are you there? Switch your mic on if you're there. Are you there, Shref? We can't hear you, but I see your mic is on. So maybe there is a glitch in the system somewhere, but your mic is definitely on, but we don't have any sound from you. Well, welcome. If you have any specific questions, put them in the chat box and we'll figure it out before next time. You can work on it, but welcome back from last week. Jay Kruckman, question. Your question.
Well, actually, Rick, Peter answered most of my questions for this evening. If you want to pass on me now, and if there's time at the end, come back. That'd be great with me.
That's very kind of you. Jim Harrington, I am afraid that we lost Eric. I think he's hung up.
Oh.
But if I see,
yeah, I just want about I wanted to ask him about a treatment that he was getting. He mentioned last week. I didn't have time to ask.
Okay. What treatment was that?
Well, I just want to know about his chemo. What side effects he had. I think he's been on 2 chemos. Do you remember? And he seemed to have a hard time. I just was wondering. But if he's not on the call, I can just wait unless you remember.
Hold on a minute. Who just joined us? Somebody just joined us.
This is Eric.
Perfect timing. Perfect timing.
Good timing, Eric.
Perfect timing.
I'm in the hospital and I had to get off for a minute.
Oh, I'm so sorry to hear you're in the hospital. Okay, so we'll go to Jim's question for you, and then we'll go to you.
Yeah, it's a quick question. Eric, last week we were talking, it was at the end of the call. I didn't have time to ask, but just go again over the chemos you've been on and the side effects and how you've been dealing with them, because I'm also going through Taxotere.
Oh, well, I did Taxotere 3 years ago. Yeah, 3 years ago.
Oh, 3 years ago. Okay.
And it kicked me on my ass.
Really?
I lost
how many
pounds.
treatments? Oh, wow.
I had six treatments.
Oh, did it do any good?
I'm still alive.
Yeah, well, there's that.
That's about all I can say. I did not seem to reduce the mets any. But it was done on the basis of the chartered study, which said do it early.
Okay.
And so we did pretty much what was described in the chartered study.
Okay, so you had 6 treatments, but you had a tough time with it.
Yeah. I was still in favor of doing more chemo rather than not doing it at all. So now I'm on carboplatin and Jeftana, also known as cabazitaxel. And they started out on the carboplatin weekly, and then after 4 sessions, they started the Jeftana every 3 weeks, and so now I have both of them every 3 weeks. And at about day 3, I kind of get sick, and day 7, 8, 9, around there, I get pretty weak. I've done Neulasta with each dosage except one. They decided that my white cell count was fine and we're going to do it, and my white cell count went to almost nothing, so they're not going to do that again.
Yeah, I have the Neulasta too.
And I get the Neulasta bug that they stick on you, and it gives you the shot 27 hours later.
Right, I have that on me now. Yes, I know what you mean.
Yeah.
Is the carboplatin working?
Well, my PSA went down, up, and then the last one was down again. So I was making all kinds of drastic plans when it went up, and now I don't know what to do. It went down substantially.
You were at 25.9, and what's the most recent one, Eric?
19.5.
Okay, that's. I mean, it's good to hear, and I just want to say, we'll come back to you, Jim, but I just want to say that Rob, God bless him, is doing carbo right now, and he's had, I think, about 2 or 3 weeks, and he seems to have, he's been doubling, and he seems to have peaked at around 88. And his doctor's telling him that sometimes the carbo takes a couple of months to kick in. And I know that you took it for a while before it had an impact. Isn't that right, Eric?
Yes, that's true.
I told him that.
It actually wasn't until, who knows what really happened, but it wasn't until that Jeftana was added that it went down. So.
Well, thank you, Eric. Right now, Eric, I'm just on docetaxel. I've had 14 of them, and actually, I guess I don't have the same reaction you have because I tolerate it pretty well. I don't have any nausea, and so forth. So, but I know that I'm going carboplatin next one. But my PSA is holding about 4, and with the docetaxel, so they keep. But 14. I asked how long, and they said for life. I said, what the hell?
Yeah.
But I mean, life. And then my wife says, is it 1 year, 2 years, 5 years? Every 2 weeks. And I always get my last with it. But you know what? I tolerate it pretty well. I just don't, you get fatigue and you go through the nadir. Yeah, all that's true. But I try to just say, look, get up, get off the couch and go to work. And so I do. But it's not easy. But I basically, I know as long as they'll stay on docetaxel as long as it more or less holds the PSA.
Right.
But I thank you for your comments, and sorry that it set you on your ass, as you put it. And I know many other men too on the call, Rick, too, have trouble with docetaxel. It's one of the oldest, maybe the oldest chemo. And I know eventually I'll probably go on to carboplatin. I have to do something, or maybe Jetvana too. But at the moment, this is working, and they just keep doing it, and there seems to be no end in sight. I'll set some kind of record, Rick. A record you don't want on a number of these things.
Yeah. How long does your infusion take?
1 hour. They put me 1 hour. As I always say, it looks like water. It doesn't act like water. And I've had a lot of transfusions because my red blood count goes down, but they give you a transfusion and your red blood count goes up. Absolutely does. And as they said, Jim, you're going to blossom like a flower. Well, that's not exactly true, but I've had about half a dozen transfusions, sometimes 2 units, sometimes 1 unit. It works. Boy, it brings your red blood count back up.
Oh, yeah.
That's my story. I mean, it's just a way to cure. Yeah, go ahead, Eric.
Oh, I've only had one transfusion. That was at the beginning of December, but it sure made a difference in how I felt.
I mean, you can walk out of there after 2 units and sort of skip down the hall, more or less.
Right.
It really works. It's a way to cure anemia. Absolutely. Yeah, that's right. Boom. And I always get my blood from somebody in Washington, D.C., and I always ask if it's a Republican or Democrat, and I never know the answer.
Oh, boy.
They don't put that on the label.
It is red.
It's red. Very good. Very good.
Republican.
Yeah, must be.
Do they? This is Jake, Jim. Do they do the blood infusion right before you get your chemo, or do you have to do it?
Yeah, they can. Yes, they can. Yes, but every infusion of the blood is 2 hours. So that's an hour for the docetaxel, 2 hours for each. I've had 3 of them all in one day, and it's a long damn day. So sometimes they schedule the blood on another day. But they could do it the same day.
Okay, thank you.
You're welcome.
So we're going to go back to Eric, but I just realized that I never checked in with Dennis Correa. Dennis, how are you? I'm sorry I didn't check in with you early on. I was just thinking of you because when Jim's out here, if we need a doc, then we'll go to you, or I don't know, maybe even you can get to meet Jim at some point.
That would be that'd be great.
Yeah.
Sure, I can probably arrange that. I mean, the meeting's going to take place at Canyon Ranch, which is certainly not the worst place to meet, given that the whole place is devoted to health. Good food. You don't have to have any sugar, Rick, and it's quite something to see. It's a beautiful facility, and the original is in Tucson.
What's the timing on that?
Wednesday, the 14th of March, and I'm arranging for dinner with Rick, but I can do it for others. You just have to email me.
Okay.
I mean, most people don't get into it. Of course, I've got to set this up because you never get through security. But
Yeah.
it's quite an extensive property. It's really it's beautiful what this guy did and what he set up and what his purpose was to build something that was all for health.
I'll connect you. I'll connect.
Yeah, you let me know what you want to do, and because I have to set this up. I mean, this is not something we can just. But anyway, that's the story. The 14th, Wednesday at 5 o'clock.
Okay.
So I've just checked my calendar and I'm good, and I'd be more than willing to meet with you guys.
Oh, that would be.
Have you ever been to Canyon Ranch?
No.
Well, tell you what.
But I've heard a lot about it.
maybe we should just put this offline. I don't want to take up the time. There's not a lot of time left.
Right.
Just email me the details.
I'll connect you guys afterwards, and it may.
Okay.
I don't think this meal's going to be quite as. It's going to be a little different to the one you and I had with Jay Curran.
That's probably true, Rick. But it's really going to be good.
Okay.
I mean, even when they have a dessert, it still tastes. They make stuff taste extremely good. Yeah, and it's a beautiful setting.
Okay, I'll connect you guys. I'll connect you.
Yeah, why don't we go offline with that, and I'll talk. I'll discuss it with you.
Eric, tell us what you're doing back in the bloody hospital again.
I'm just getting hydration. At least that's what I thought I was getting. But now they're giving me magnesium, and they want to give me 4 milligrams of it, and it takes an hour for each. So I'm getting 2 today and 2 tomorrow.
Mm-hmm.
Hey, Eric, is that for any heart problems with magnesium?
No, it's just low count. They
okay, I see.
Blood test.
Okay.
And the other patient in the room with me is having a nurse is attending him now. So let's see, what else was I going to say? So they scheduled up just a standing order for hydration for me. And I went in Wednesday and Thursday of last week and had hydration. And then Friday I met with my oncologist for the first time, and they sent me to get more hydration right then. So I've had having trouble keeping my blood pressure up. I was getting 86 over 58 and things like that, and so that's one of the reasons why they're hydrating me. Today I came in because, not because of my blood pressure, but because I had a severe shortness of breath. We're having a cold spell here. Well, cold for San Francisco Bay Area, and I went outside for a few minutes, came back in, and I almost couldn't breathe. I just had to lie down for half an hour before my breathing was normal. So I came on in here, and they thought that maybe I had an embolism. So I did a CT scan, and the good news is no embolism.
Good.
Bad news is they still don't know why I have this severe shortness of breath. So they're going to look into it some more. But tomorrow they're going to give me a transfusion, so it'll be my second ever. And presumably that'll make me feel better. So see how that goes.
Well, you had shortness of breath about 6 months ago or so, didn't you?
Yes, I've had it for a number of years, 3 years probably.
Okay.
This not this severe.
Oh, okay.
I mean, I felt like I was not going to make it.
Wow.
So.
Can I ask a question? How do they know that you're dehydrated? Just by looking at you? Or do they?
Yeah.
Okay.
It's sort of the standard treatment for for the low blood pressure and for general malaise.
Oh, okay. Well, good luck.
So, yeah. I am seeing Dr. Agarwal tomorrow at 4, and we'll discuss the possibilities. It's kind of, the good news is my PSA went down, but the bad news is what do we do about treatment?
Mm.
So I have the feeling that they may just continue the treatment for another cycle and do the PSA test and see where it's going then. Just hold steady state until then. But at any rate, I still want to talk to Dr. Agarwal about the other possibilities.
So
they have my latest bone scan and CT, and so they've been looking at those. Go ahead.
Do you know what the latest bone scans and CTs say, Eric?
Yes, the bone scan said that the existing Mets do not appear to have grown any. However, there are 3 new areas on the ribs that they think might be new mets.
Uh-huh.
So they're going to look more closely at those.
Okay. And the CT, are they, is there any soft tissue involvement anywhere or not?
I'm sorry, any what?
Soft tissue involvement?
No, they still don't have any evidence of soft tissue involvement.
Okay, great. So,
you know, except where it was close to the spine.
Okay.
Oops,
so just a reminder, Eric. Just a reminder for Agarwal, to check in with him about this ES414 that we talked about at length with David Sibley.
Right, I have notes from that discussion. I don't have them with me right now, but I do have. Oh wait, maybe I do.
Did
anyway, yes, I took notes on that.
Okay, so you did hear the discussion with David. I think you were on the line, and with Bill, because both of them contributed to that discussion. And then the other thing is just to talk to Agarwal as to whether, you know, the view that Rob Beniscus's GU Medonc takes, that maybe carboplatin on its own, or maybe more effective than with the Jevtana. On the other hand, you did try that, and you seem to be getting results. You know, I guess one could say if it ain't broke, don't fix it. But I'm just passing on. I'm just passing on what Rob
observation. Yeah.
Yeah. Okay. I want to try and get. Does anybody want to talk to Eric? We can go. We'll probably be going over by about 10 minutes, so I can get to everybody today. I apologize. Anybody want to talk to Eric? Okay. Eric, good luck, and please let me know how you do with Agarwal tomorrow. And I hope to goodness everything goes well, so you can get over to UCSF on a timely basis.
Yeah, actually, tomorrow's call is a video.
Oh, fantastic! Great.
Yep.
I'll second Rick. Good luck.
No, thank you.
Thanks, Bill. Yeah, keep us posted, and I hope you. Do you think you'll get home tomorrow or not?
Oh yeah.
Good. Good.
Yeah, my appointment's at 9 in the morning, so I should be done early afternoon.
Okay, great. Okay, keep me posted. Send me a note or something, and we'll go from there. And okay. J Bob, go ahead.
I went on Zytiga on February 5th, and my PSA had been rising every month, doubling, and so at that time it was 101, and on the 20th of February it had gone to 54. So is that kind of normal, or is it better than normal?
So just repeat that again. You say that you started Abby the beginning of February, and your PSA went from 101 down to 54. Is that right?
Yeah.
Yeah. I think we discussed that last time, if I'm not mistaken.
Oh, okay.
I think you asked that question last time.
Okay.
What's it done since? I'm just looking at my notes, so I do have that in my notes. So we must have discussed.
I haven't had a test since, so one will be coming up the next week or two.
Okay. Well, let us know how it's doing.
Okay.
I can say this to you, and the other guys, anybody who's doing Zytiga or has done it can chime in. But the fact that you got a response, such a good response within a short period of time, is positive, because it means, number one, you're not ARV7 positive, and number two, you're responding to the drug. And some people take a lot longer. Anybody want to talk about responding to Zytiga?
Well, for what it's worth, I was only on it for 3 months, and the first 2 months my PSA went up slightly, and then it started going down in the 3rd month. And for other reasons, I just decided to give myself a ADT holiday. But just for everyone else's information, there is such a thing as Zytiga flare, where initially your PSA might go up a bit.
I forgot to say that I'm on Firmagon also.
Right. Right. That's pretty standard. I don't know of anybody that's done Zytiga and they're not on an LHRH drug.
And if there's time, I just got a question about prednisone.
Go ahead.
I do have a little shortness of breath, but I was having that, but not as extensively as before. I'd say my blood pressure maybe gone up about 20 points, but it goes back down when I lie down if I'm exerting myself.
What's your prednisone dose? This is Dennis.
It was 10, and they dropped it back to 5. I guess they do that.
Twice a day or once a day?
No, I do it in the morning.
5 milligrams all at once?
Yeah.
Yeah, I split mine up. I take 2.5 in the morning and another 2.5 at lunchtime, and both times with food.
Okay.
I seem to recall that shortness of breath is a known side effect from prednisone. Am I right or wrong, or can anybody help me with that?
Rick, I take prednisone, and I do have some shortness of breath too, but I tie it more, not so much the prednisone, but the chemo. And by the way, there is a possible way around this when you start it and really getting it bad, and there are psychopharmaceutical drugs. I talked to my med-onc about it. She said would not prescribe them. Well, one of these drugs would be Ritalin, give you a shot, a boost. You can read about it, but I've never heard anybody who's done it, and my med-onc wouldn't do it because that just is an artificial boost, and it's one of these drugs that people hear about. So it's a thought.
Yeah.
But I've never tried it, but I think it's caution would be.
We know a bunch of people that have done it, have done Ritalin. I can think of 4 or 5 off the top of my head. Some it has an effect, others it does not. UCSF is usually willing to prescribe Ritalin.
Oh, really? Okay. My med-onc would not. So, but it's okay. It's not that bad. So.
Okay. But it's really the shortness of breath that I don't know if the Ritalin would help with the shortness of breath. It's usually for fatigue.
Yeah, that's true. Well, I sort of put them together, fatigue, and they sort of come together with me. But you're right, that's possible. I don't know what you do about the shortness of breath. I mean, I have it too with the chemo, but live with it. But that was scary.
I think probably, Bob, what you should be doing is reviewing that with your doc and asking them about shortness of breath. I definitely think it's worth. And also, have you told them about the increase in your blood pressure from time to time and the shortness of breath?
No, I'll have to do that.
I would. I think that those are the sorts of side effects that you have to report.
Okay.
Yeah. I think your transfusions are going to help you too. Just keep getting more blood, and I think it'll.
He's not getting Bob. No, we're talking to Bob Dunn now.
Okay. Sorry. Okay.
Yeah.
Sorry.
Yeah, Eric is left, by the way.
Yeah, I saw.
Oh, okay.
Yeah. So Jay, I do think you should raise this. Definitely send a note to whoever's looking after you at this point in time, and tell them that these are issues, and you just like to talk to somebody.
Okay.
Yeah, Rick, I believe that shortness of breath is much more highly likely due to the ADT rather than prednisone.
Could be. Could be.
Yeah. As a matter of fact, here's a little blurb from something. This is from PubMed. It says, although anecdotal reports pointing to the occurrence of episodes of shortness of breath due to prednisone use have been published, systematic evidence is lacking.
Okay.
Yeah, I would agree with that.
Thanks, Len. But either way, I do think you should report these symptoms to your doctor.
Okay.
Okay, Tom, we're right. It's already 8:05, so I'm not going to get into I'm not going to get into this issue around exercise right now. But please bring it up again, or if we've got time, I will raise it. But the elevator version is that I've heard in diabetes clinics that patients are able now to get referrals to see physical therapists. Excuse me, you've always been able to see physical therapists, but they're able to get referrals to see exercise people, exercise physiologists. That's what I meant to say, not PT, but exercise physiologists. And I'm working on this, and I'll keep you guys posted. We're working on trying to set up some sort of program and a call for diabetics, and that's where I'm learning a little bit about this, and that's where I heard for the first time that you can get exercise physiology consult on Medicare. So I'll start looking at it, and the PTs are great, but they're very focused. And they don't really get into exercise per se. They get into rehabbing you from an injury. And the problem is going to see a PT for something very general like fatigue or what have you. I've never found anybody that's really got a benefit from it. But you'll tell us whether you do or you don't. Anyway, but we'll come back to that one. But thanks everybody. It's a crowded call tonight. Lots going on. Dennis and Jim, I'll connect you within the next hour or so, and we'll speak to you all next Tuesday, right? The 5th, the 13th. We'll speak to you all on the 13th. I'll try and get this call posted quickly because I know there's a lot of good stuff in it that some of you may want to listen to again. Good night, everybody.
Good night.
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 Night.